I'm Dr. Ines Werner. I'm now president of the European Society of Cosmetic and Aesthetic Dermatology, the ESCAD. And I'll talk about resurfacing 2017, where do we stand? I have no conflict of interest for this lecture. So it was Hippocrates who said that wherever the art of medicine is loved, there is also a love of humanity. And the natural forces within us are the true healers of disease. And in this concept, I would like to continue talking about skin resurfacing and how our natural wound healing mechanisms, our natural forces, can lead to healing and building of new skin. So aging has different things on our skin, like wrinkles, dyspigmentation, solar lentigines, rough skin surface, sagging, volumetric changes, solar keratosis. And interestingly, the histological changes that accompany some of these clinical changes are found mainly in the epidermis and in the upper dermis. So they are on the surface of the skin, and therefore these changes are amenable for skin resurfacing. And I finished my residency, dermatology residency in 1998, and I entered into the aesthetic field then. And in 1998, we had some chemical peels, we had some lasers, mainly the CO2 laser for skin resurfacing, and we had some IPL systems. And this is one of my patients that I peeled at that time. This is her before and after, and this is a medium depth chemical peel. So you see improvement in pigmentation, some improvement in the small wrinkles, but no improvement in sagging, so there is no skin tightening. And this is another patient before and after a deep chemical peel. So here you can see that not only there is improvement in pigmentation and small wrinkles, but also skin tightening and lifting effect. This is another patient that I peeled many years ago, also a deep chemical peel, fantastic results, but what you can see is that there might be a little bit of a demarcation line at the lower edge of the face, at the mandibular border. And this is another patient whom I also peeled, and she had a more pronounced demarcation line. The reason for that being that there was a delayed hypopigmentation after these ablative treatments, and also we did not treat the neck. So deep chemical peels or deep ablative resurfacing actually gave us great results, but it was a difficult procedure that needed general anesthesia with cardiac monitoring, difficult healing time, longer downtime, and a risk for scarring and hypopigmentation. And at that time we knew that superficial peels will improve dyspigmentation, that medium depth peel will improve solar lentigines, solar keratosis, and small wrinkles, and the deep peels will actually improve the deeper wrinkles and sagging as well. And also we knew that if we peel superficially, we will always see great tissue regeneration. If we go deeper, we actually risk more side effects, a little bit more of a difficult wound healing time for the patient, and of course more risk for side effects such as even scarring. So at that time we also had ablative and non-ablative technologies in the laser field. So the ablative technologies actually ablated the skin, the epidermis and the dermis to a certain depth level, and actually were most effective, had fantastic efficacy, but also had a long downtime, some erythema, some risk for hypopigmentation and scarring. The non-ablative technologies that were available at that time had few side effects and actually no downtime, but their efficacy at that time was very, very limited. Now, the big change in this whole field of resurfacing actually happened in 2004. And in 2004, Dieter Manstein from Boston introduced fractional photothermolysis. And fractional meant that you take columns of laser light or any other technology and you actually treat columns of skin going into the depth, but on the other hand, you keep the skin between the columns intact, and so that the wound healing will not only be from the edges and the hair follicles, but also from the areas that were not treated, which meant less side effects, faster healing, and still a very good efficacy. And this is a representation and adaptation of something from one of Dieter Manschen's lectures. And he said that if you treat 25% of the skin like this, like a quadrant, versus if you treat it by little points, also 25% of the tissue effect is completely different. And so when you treat by separating the treated areas with normal skin, we are able to really achieve tissue regeneration. And so in fractional resurfacing, cells migrate not only from the wound edge and adnexa, but also from the non-treated skin area, so that the healing is much faster, there is less risk for side effects, and we have the possibility for true tissue regeneration. Now these are slides, pathology slides of a fractional CO2 laser. Here you have 5 millijoules on the skin, and here 20, and with 20 you have of course more ablation, you go deeper. The coagulation area around it is also just a little bit bigger, but mainly you go deeper with your ablation. Now what happens after 2 days is that already after 2 days there is reepithelialization of the skin, which is very, very fast. And after 3 months, we see neocollagenesis. This is how patients look. This is the patient on day 2 and day 3. They're inflamed, they're red, but it is much, much less than with the ablative resurfacing we were used to do. Now, these are slides, that's pathology slides, showing staining for HSP47. Now, HSP47 is a marker for new collagen formation. And what you can see is that at 1 month, you have HSP47 formation at the level of where you treated the skin. So at the level where the laser actually hit the skin. But at 3 months, you have HSP47 overall, which means that you actually have overall new collagen production, not only as a treated area, but also in the area surrounding that area, which is very, very good. So we do see also delayed results. And we see that on our patients, that not only we see direct results, but also results, improvement of the results a few months after the resurfacing procedure. So fractional resurfacing was easier healing time, shorter downtime. We're now able to give actually ablative fractional resurfacing, mainly with the CO2, with only 5 days downtime and a much lower risk for side effects. That means for scarring and hypopigmentation. And I'd like to discuss a few of these technologies. I'd like to discuss fractional ablative CO2 lasers, fractional non-ablative lasers, fractional microneedling radiofrequency technologies, and fractional minimally ablative radiofrequency technologies. So the fractional ablative CO2 laser is, I'll talk about the AccuPulse. The CO2, what is interesting about the CO2 is that this is its wavelength, and as you can see here, it is in the ablative range. So all wavelengths about 2000 nanometers are ablative. So it ablates the skin when you treat with it. Now, when we treat in the clinic with this laser, when we do a fractional ablative treatment on a patient, we don't need a general anesthesia, so just a topical anesthetic will be enough. The healing time is much easier on the patient, it's faster, mostly 5 days will be enough to to finish the peeling process, the erythema, swelling and peeling afterwards. And the redness after the treatment is also much less. It will be something between 2 weeks to 1 month, and as I said, lower risk for side effects. Now, interestingly, this laser, the AccuPulse by Luminis, actually already at 30 millijoules per pulse already has 1,000 micron depth of ablation, which is very, very good because 1000 micron is exactly what we need to get rid of the deeper wrinkles. So it's a low energy as compared to other lasers, so which means that you have less side effects, less swelling, less redness, and also less collateral heating, which means you will have less risk of hypopigmentation, less risk of delayed hypopigmentation later. So the good thing is here is the very high ablation coagulation ratio, which means that we go deep already at quite low energies, which gives us a lot of safety during and after the treatment. So these are the different modes. You can treat deep, superficial, or combine both modalities, and these are some pathologies. And here are some clinical results. This is 6 days after, before, 6 days after, and here again before and 6 days after the treatment. So there is a mild redness, not as with the treatments we're used to do in the past. This is another patient, also fractional CO2, and another patient fractional CO2 laser. Now, another technology is fractional non-ablative. Now, interestingly, in the past, the non-ablative technologies couldn't give us the results that we wished, but nowadays they are able to give us fantastic results without downtime that we have. So actually there is nearly no downtime after the non-ablative treatments. So this is the wavelengths, it's well absorbed in water, so you have a very good efficacy, and on the other hand it is still non-ablative. So here, this is the device. It's actually on a platform, M22 platform, but you can also have it separately. It's a 1565 wavelengths that actually gives columns of coagulation inside the skin, with actually a lot of the stratum corneum staying intact. These pathologies, these are clinical results before, after, and you can treat off the face. Now, microneedling RF, I'll discuss Legend also by Luminis. It's a very nice device of radio frequency. The new thing with radio frequency nowadays is the microneedling RF, which goes deep into the dermis and actually doesn't touch the epidermis. So it's also a kind of a non-ablative resurfacing, but here you have more heating that spreads out in the dermis, leading to very nice tissue tightening. So this is the technology. The pins go into the skin and they actually heat the skin in the dermis, inside the dermis. This is some skin and the visualization. Interestingly, these technologies can also be used on acne scars and can be also very effective for acne, active acne. This is very interesting. And this is another microneedling device by Fractora, another company. Also deeper pins, very nice coagulation, and also very nice clinical results after the treatment. And here again, you can also treat acne scars and also active acne. Now, the last device is another radio frequency device, which is also actually works very nicely, as it has sharp pins that enter into the skin, and it combines actually the sharp pins radio frequency together with an IPL. This is how the pins look. They are sharp and they enter into the skin, and you can control the level of ablation and the level of coagulation. And here you have some clinical results also before, after, and this is before and after, which actually also looks very, very nice. So we have different technologies, and we have discussed ablative, non-ablative, and fractional radiofrequency technologies, and they're all very interesting. And we have many, many different possibilities to use these technologies, and also sometimes to combine between them for different indications. And in 2017, we can offer our patients great results with milder procedures than in the past, with minimal or no downtime at all even, and much less risk for side effects such as scarring and hypopigmentation. We should be acquainted with the possibilities and limitations of the different devices to be able to offer to our patients the best treatments. And thank you. Thank you.